Hello and welcome to the Love Mia Vita podcast, sponsored by Fem Pharma. I'm Jerry DiPiano, founder and CEO. Thank you for joining us as we discuss all aspects of women's healthcare. Please note, this podcast is for educational purposes only. Always refer to your healthcare practitioner for personal advice. Welcome to the Love Mia Vita podcast, Dr. Courtney Schreiber. Today, we are going to speak about pregnancy, early access, and the center that Dr. Schreiber has established at the University of Pennsylvania in Philadelphia, Pennsylvania, which is the first of its kind. And I think I'm correct, the only one of its kind in the nation. Or perhaps there are others that have gotten on board, but clearly this is extremely important. I'm going to chat about a number of different offerings that Penn and Dr. Schreiber have as part of this Pregnancy Early Access Center, because it does not only include things like early pregnancy access, but services that really cater to women through their journey.
That's
So,
right.
Dr. Schreiber, tell us a little bit about your background.
Yeah. I'm so happy to be with you today, Jerry. So thanks for this opportunity. I'm a professor of obstetrics and gynecology and have spent my career building, innovative programs and filling gaps in the delivery of reproductive health care for female patients. And I'm a physician scientist, so I have this great opportunity to really learn from patients, the people I see and care for, what it is that they're looking for, what it is that they need, and then applying what they bring to my attention as their concerns in the scientific realm to try to fix those problems on a public health level. So it's a great sort of combination of activities that I get to do in my job, and of course, and as a professor, I do teaching as well. So I can take other young people through that journey of how do you have a certain level of curiosity when you're in the clinic delivering care, that you can start to see themes of the needs of patients. I know, there's been a lot of in, information and discussion on social media channels, for example, about IUD pain, right? So pain with the insertion of an intrauterine device has gotten a lot of attention on social media. And actually, the CDC has changed its sort of recommendations around IUD placement and counseling to include attention to this issue of pain. And that really did come from sort of patient demand. Well, we heard about that, 10, 20 years ago. We were listening to our patients and knowing that it's just completely unacceptable to put somebody through intolerable pain for receipt of a contraceptive device. And so many years ago, we studied that. And my group was, one of the first group of scientists to put out rigorous data on how to mitigate the discomfort with IUD insertion. And so because we A, listened to the patients, B, asked the question in a rigorous fashion, then we were also early adopters of our own science, of course. And so patients who come to us for IUD insertion are going to be offered a variety of different interventions to reduce the discomfort of an IUD insertion, and we offer that to everybody. And so a patient doesn't even have to think about asking for it. We preemptively say, we know this is going to be uncomfortable for you, so these are the offerings that we have that are evidence-based to reduce your discomfort so that you can choose the contraceptive that you want and that fits you best, without having to worry about it being a miserable experience. So that's just one example of the type of what it means to really be a physician scientist. And early on, honestly, Jerry, when I was in my training, so still going through training, I have always been focused on helping individuals to achieve their reproductive life goals, to prevent pregnancy when that's what they're looking for, and then to help them to conceive pregnancy in a healthy way when they're looking for that. And it's may sound straightforward, but it's actually complicated because people bring so much to their reproductive lives and have their own value systems, their own needs, their own timing issues, their own restrictions, or even health issues that may make, for example, trying to prevent pregnancy more complicated for an individual if they have other health conditions and some contraceptives may not be appropriate for them, or maybe they don't tolerate the side effects. So, really focused on helping individuals to achieve those goals. And as I was developing that clinical expertise and niche, I would get referred a lot of patients who are having early pregnancy loss or miscarriage concerns. As a person who was, as a clinician who sort of kept my focus of my practice on those individuals who are having family planning or reproductive health care concerns. And while we often think about like the need for abortion or needing to end a pregnancy as one of the kind of most underserved areas or stigmatized areas of medicine, and I don't want to say it's not because it is, what I really learned through delivering care to patients who have a variety of problems with their early pregnancy is that even more than actually needing to access abortion care, finding a provider for miscarriage management is extremely difficult. So I started observing the journeys of these patients. We've studied that. We actually learned that it can take up to 60 days, 2 entire months, for a patient to resolve a diagnosed miscarriage in the sort of traditional healthcare system. And you may say, well, how could that possibly be? Why is that? And it's because really obstetrical care, so the care of a pregnant person, whether it's by an obstetrician or a family medicine doctor or a midwife, but the system of obstetrical care is set up from a billing perspective where the clinician really gets paid essentially at the time of delivery. And we even label it that way. We talk about prenatal care as being pregnancy care. Those are interchangeable words in the United States. Like we think if you want to label pregnancy care, it's called prenatal care. But actually, as many as 40% of pregnancies don't end in a baby, Jerry. 40%.
I was shocked to see that statistic.
It's pretty remarkable. That's
Yes.
an enormous cohort of patients that actually don't have a system of care built around them because prenatal care is set up so that the reimbursement happens at the time of delivery, which then therefore means that that 40% who don't wind up having a baby don't really have a place to be seen. And so they use Google, people and
Or
this,
Reddit, or
uh,
Reddit today, or Reddit.
yeah, exactly. Madly searching for information online to try to figure out what a symptom might mean. So you maybe had a positive pregnancy test 2 weeks ago, and you may have called to get in for your first appointment, but that's going to be a 2-month wait for most patients. And so while people are waiting to get into that care, that's actually when the most common complication of pregnancy occurs. So miscarriage or early pregnancy loss is the most common complication of pregnancy. That's usually occurring during that period before prenatal care is established. Ectopic pregnancy, or the pregnancy's in the wrong place, in the tube most commonly, that's one of the deadliest complications of pregnancy. And sadly, in the United States, like women still die from that condition. And then, of course, that's when most pregnancy decision making is happening. So if you weren't expecting to be pregnant and you find out that you are, you have to sort of grapple with what does this mean for you and whether or not this is the right time for you to continue that pregnancy. And most of that decision making is also happening in that early first trimester time. So we built a program called PEACE, the Pregnancy Early Access Center, that delivers care for that population of patients. It is comprehensive first trimester care. I mean, the other part of this, Jerry, of course, is that the most important things in a pregnancy are occurring in those early stages. That's when
Yes.
embryo development is taking place. That's when it's so critical if the pregnancy is a wanted pregnancy and it does continue to maximize the health condition of the pregnant woman or person, like get chronic conditions under control so that this pregnancy has its best chance at being healthy in that particular setting. Managing, sort of issues around medications that people may be on chronically. And so there are a lot of questions that happen in those early weeks, and it's difficult to find answers from a clinical team. And so we built the program. It's about 15 years ago now, and I'm happy to say you asked about if there are others, and there are now. So there are about 80 to 100 similar types of programs now across the country because this truly winds up being an example of high value care. So not only is it patient centered and it's meeting what was otherwise a gap in care, but it also reduces costs for patients and for health systems because it's keeping people out of the emergency room unnecessarily. We did another study that demonstrated that of the almost 2 million emergency room visits in the United States every year for early pregnancy concerns like bleeding and cramping or nausea and vomiting, 95% of those patients are discharged without any kind of major intervention, meaning they probably didn't need to be in the emergency department in the first place and would have been better suited to ambulatory care or care in a clinic. They just couldn't get in.
Right.
So it's sort of like urgent care for pregnant
Mhm.
people in
Right.
those early weeks. And as I say, it's truly is an example of a high value healthcare model. And so because it's such a win-win like that, I'm happy to say that a lot of other health systems have integrated similar services.
You offer so many important services to women, and so we talk about early access, pregnancy early access care. I love the acronym, by the way, PEACE. It does give one sort of the comfort at a time when your body is changing. And
That's
even if you've had other pregnancies, every pregnancy is different, right?
right.
So when you are feeling unsure of what's going
Mhm.
on in your body,
Mhm.
makes sense to me to think about that as an acronym. But you offer so many other services. You talked about early pregnancy loss. You talked about abortion care. You talk about contraception, HIV prevention, and family planning, and then postpartum contraception. All extremely important services for that population. And I'm always curious about whether all members of the community can avail themselves of these services because let's
Mhm.
face it, there are disparities. There are
Mhm.
disparities right here in Pennsylvania, in
Mhm.
Philadelphia.
Mhm.
Black women, and other minorities are not necessarily given the same level of care or consideration. And, we have many data points to prove that. So we do understand that these services are really important, and in particular in cities where you have diverse populations.
hmm I really appreciate you bringing that up, Jerry. That was honestly a central tenet of in the founding of this clinical service for me. Having throughout my training and even early as a faculty member, been at different institutions where care was so segregated depending on what type of insurance or whether a person was insured at all for pregnancy related care. So out of the gate, the most important approach for me was that everybody was seen um, in the same way by the same clinicians, regardless of their payer status or their insurance coverage status. And honestly, in medicine, there's this the concept often of the VIP patient, who is the very, and typically you think of the VIP patient as being somebody who knows the CEO of the hospital, or, knows the dean of the medical school, or is that person who needs like special ushering in. For us, the VIP patient is the patient who needs the most. And that's true health equity, right? That you provide extra care to the person who needs extra, that you facilitate the access to the individual who needs that facilitation most, who may have transportation problems, who may have childcare problems, who may have so many health issues or social determinants of health issues that getting in is their biggest challenge. And so we really have structured our clinical model to put those who need most first. And I've actually had patients say to me, patients of privilege say to me, I feel so lucky that I was able to get in the way that I was. And I'm very fortunate, and I'm sure it's because of my like social status or the situation, the person who referred me to you. And I say, actually, no, like I treat everybody exactly the same. And the access experience that you had is the access experience that all of our patients have. We built that in to our model. And so we actually just did an analysis of the most recent sort of 5-year period of our program. This isn't published yet, but the manuscript will be submitted soon. That showed that the population served most by our services is actually the population that's insured by Medicaid, and that those individuals are getting are accessing our services more than individuals who are privately insured. So we are serving the needs of the community broadly, and it makes sense based on where my institution is situated in the city. That is the population. Those are our neighbors, and that's who we should be serving. I think about this. I think the one other point I'd like to make related to health equity is that uh, when we talked about the enormous number of emergency room visits for early pregnancy concerns, that is also disproportionately experienced or needed by people who are of color, as you say, people who are poorer, and people who use Medicaid for their insurance. So just by its inception, this idea of having urgent care in the ambulatory setting is helping to reduce kind of the time off work, the additional cost, the costs of childcare that are required if you're going to wind up being in the emergency room for 24 hours, which is very common for a problem that could have been resolved in a scheduled visit in the outpatient setting. So it is both a high value care model, a patient-centered model, and a model that supports health equity.
And if you're a woman that does not have an OB-GYN,
Mm-hmm.
and you find that you are pregnant, right? So you use whatever is over the counter to determine that you actually you are pregnant, or maybe you don't know, because let's face it, women may have irregular periods, they may have different types of pregnancy symptoms, or they don't recognize that it's the same pregnancy symptom that they may have had with prior pregnancies. So
Mm-hmm.
maybe they had some spotting when they were pregnant. And so this time around, if they had spotting, they're not going to go and check it out with their OB-GYN until things become pretty significant. And now they end up in the emergency room, but they don't really have good care. You mentioned prenatal care.
Mm-hmm.
If you don't know you're pregnant, it makes it very challenging to seek out prenatal care if you don't have the resources to engage with an OB/GYN. And
Mm-hmm.
you're left um, trying to figure this out on your own until you reach the point where you're ready for delivery, assuming that things continue to progress in your pregnancy. Years and years ago, I worked in an emergency room. And the thing that struck me, it was in a city, it was actually in Trenton, New Jersey. And the
Mm-hmm.
thing that struck me was that there were women that would come into the emergency room and they did not know they were pregnant, and they were in labor when they came into the
Mhm.
ER.
Mhm. Yeah.
And that it made me sad, but
Mhm.
it also was the first experience that I had with the
Mhm.
inequities
Mhm.
in healthcare.
Right. Yeah. And there certainly are, subpopulations that this affects more than others, but the truth is it affects everybody. You know, there are 20 million pregnancy tests sold in this country every year. I mean, it's a multi-billion-dollar market, the pregnancy test market. And and a person's life is changed immediately. No matter how that positive pregnancy test affects you, it is a life-changing moment to look at that positive pregnancy test. It may be received with joy, it may be received with dread, it may be received with just surprise and I don't even know what to do next, but it is an identity-changing experience, and it's happening constantly in this country and in the world. And there's no real linkage then to care and evidence-based information. So that's really the gap that we are trying to, that we are filling and that we aim to continue to fill. And and so that people don't feel like they're left out in the breeze and having to make judgment calls and difficult decisions about their health and well-being in those early weeks of pregnancy, but they can actually access holistic care to meet whatever their needs are at that time.
It's interesting. I know trust is a big component, having trust in your provider, and you share
Mhm.
a little bit about that because I've done my homework, so I've
Mhm.
read your story and know a
Mhm.
little bit about your story. But would you share the story of, and again, this is all anonymous, of course, we're not
Mhm.
disclosing any patient identities, but share with our audience how you build that trust. Share the story,
Mhm.
if you will.
Yeah. I think I'll tell you, Jerry, I have really evolved in this over the years of clinical practice. And that's one of the things that uh, is so valuable. There's so much about medicine that is an art. And that trust, that work on the trust component of the physician-patient relationship for me is always evolving as a creative process of trying to learn from my patients what it is that I can do better to 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 break down those barriers, and especially for Black women and women of color broadly, for too many to count horrific good reasons. There is a lack of trust in the healthcare system and in individual physicians. You know, Black women and women of color have been experimented on unethically, have had their autonomy completely, I mean, to say undermined is actually an understatement, but have been horrifically treated. In terms of, sterilization without consent and experimentation with contraception. And then we know still that maternal morbidity and mortality rates are egregiously higher among Black women, even when we control for socioeconomic status. So it's not a socioeconomic status thing, it is a color of the skin thing. So I would say that, one of the ways that most recently been working on building trust is actually just to call those things out with my patients. They know it, I know it. So let's just talk about that and not pretend that that doesn't exist in the world, and call and just, making it very clear that I value them as an individual, as a whole person, and there may be things that I'm missing about what are their values and what's important to them, but I want to hear those things. I don't come into any room with assumptions. I'm there to learn. And once I do learn, then I usually can make offerings and have conversations that are the most helpful to getting a woman on her journey to where she's trying to go, or a female patient on their journey and where they're trying to get to. Um, so, just respecting that everybody brings their own stories with them. And some of those stories are created by structures and history. And that's all part of who we are. And acknowledging that up front is something that I probably would have been afraid to do or thought was taboo many years ago. But I find it to actually be really helpful. I mean, if you can talk about, like, think about the idea of anemia, right? So this is not necessarily related to fertility or early pregnancy, although it can be. The problem of anemia among women broadly, but Black women specifically in our communities is horrifying to me. People walk around with very low blood counts, and that diminishes their energy levels, their ability to engage in work, their ability to engage at home. And, heavy menstrual bleeding, fibroids, multiple pregnancies, because every person becomes more anemic in pregnancy than they were when they were not pregnant. So there are so many, it's a multifactorial problem, but it's a problem that has to be tackled head on. And depending on the community, or maybe what the women around you experience with menstrual flow, for example, you may think that something that is very heavy and can be dangerous to yourself is normal. And having those conversations in a very straightforward way, like, I'm not trying to push therapies on you or push drugs on you or make decisions for you, but I'm trying to help address because there are many contraceptives that also can help limit anemia and heavy menstrual bleeding. So, like, how can we tackle all of these problems in a way that works for you and make you feel better, and be able to show up to work feeling better, and show up for your kids feeling better, and show up for yourself feeling better. So just calling it out, like, it is unacceptable to see strong women not be able to work within their, like, full power. And anemia is a big reason for that. We got to tackle it.
We've heard this from you. You mentioned this earlier. Some part of this is about the socioeconomic issues that impact women, but a lot of it has nothing to do with socioeconomic. You're right. It's just the skin color.
Mhm.
It's very sad, and you're right. We have to acknowledge it, and we have to work on the change. It sounds like that's what you and your team at
Yeah.
the Pregnancy Early Access Center have worked on.
Yeah. I mean, it's a big part of what we do is truly trauma-informed care. And honestly, Jerry, it's kind of impossible to be a woman, and given the level of misogyny in our country, and to be a Black woman intersectionally experiencing racism and misogyny, to not need trauma-informed care. That's just the baseline. Everyone needs it, and people need it to different degrees. But to have that awareness about the baggage and the systemic horrors that people are experiencing, they're bringing all that into the clinical room with them. You can't shed that, and it's part of you. So, working on the acknowledgement of that as being the first step to being able to have real conversations that then we can help you clinically. But we have to have that rapport, and I have to feel like I can hear exactly what it is that's concerning you, and that you're not holding things back because you've been conditioned that you're not supposed to say certain things or hold things back. Um, and many people might think that that takes a lot of time, but it doesn't take a lot of time. It takes careful attention and expressing true empathy. Um, and that's part of this clinical skill set that all of us should be able to bring to a clinical encounter.
Well, we love the work that you're doing. It's so important. I'm happy to hear that you were the first but you're not the last. That there are
Mhm.
many other centers. And I know at the UPenn website for Peace, you talk about how to establish your own clinic.
That's
So if
right.
anyone is interested in doing that, there is at the University of Pennsylvania Peace website link. You can find information if you're a clinician and you are interested in doing that. You can check that out and figure out how to, with the help of some of the experts like Dr. Schreiber at Penn, establish your own center because this is something that is so needed. So
That's right.
we are still facing a public health crisis where women are concerned. We cannot ignore that. We have not solved all the problems, but we are doing this one woman at a time,
That's
with
right,
Dr.
Jerry.
Schreiber being one of
Mhm.
those trailblazing
Wow.
clinicians. So I want to thank you for being part of our medical advisory team. So Dr. Schreiber has agreed to join the FemPharma Medical Advisory Board. And I want to thank you for being our guest on the Love Mia Vita podcast.
Thank you so much, Jerry.
Thank you for the great work that you and your team provide to women.
And thank you for helping to amplify it and for all the work that you do as well. And it's such a pleasure.
Thanks. Thank you for joining us on the Love Mia Vita podcast. Love Mia Vita means love my life, and that is a mantra we should all live by. Please like and subscribe wherever you get your podcasts, and remember to follow us on social media and on fempharma.com. Thank you and be well.